Yes, okay. Thank you, AIOS. Thank you, Madam ma'am, Chairman Dr. Tityal sir, and Dr. Maipal, and the moderator, Dr. Partha, Dr. Anaga Heru, ma'am. Thank you for this opportunity. And my talk today is about making sense of biomechanics and its future. These are my financial interests. What's the modern use of biomechanics? The modern use of biomechanics is in many things. For example, it started off as tracking the progression of keratoconus. Basically, that was one of the, and refractive surgery in trying to detect mild cases or early cases. I feel that has a huge role in understanding the myopia progression, which is something which we have not really looked for. Detection of post-LASIK ectasias. There are many other areas which we have worked on in the past, which I feel has its progression as even in looking at which of those patients with papilledema would go in for visual field loss, and also looking at some progression identification. So this is what we published in the NANOS meeting few years back. So it's just not about picking up for refractive surgery. Refractive surgery probably is one of the many areas of what modern biomechanics can do. So when you look at these kind of images, we just look at one parameters and say that, okay, these are the parameters which we look at and say that this parameters will help us to pick up the weak and the strong corneas. I think that philosophy of just looking at one or two images and making a judgment is, I think, very outdated and very obsolete in today's context. So this is what happens when a refractive surgeon wants to look for it, because we are not looking at one parameters what we used to look at a few years back. Now there are different ones. One is the dynamic corneal response, which we always know how the cornea responds. The Vinciguerra screening response has multiple parameters. The new CBI, TBI maps, and biomechanical comparative display, or your new SSS stress strain index with all the new features which is there. So what started off just as one deformation amplitude is completely obsolete now, and that's why we are able to understand it better. The new biomechanical parameters which we've been speaking about, the CBI, TBI, and publication, which shows that they're quite sensitive. But there are a lot of controversial issues which we need to look for as we move on. What is the real truth out there? One of the major challenges for any of this is, if you look at these cases, you can see that the first 1, 2, 3 cases are not abnormal cases. And you can see the keratoconus are completely different. 1, 2, 3, 4. You can see that the CBI, the corneal biomechanical index, and the topometric biomechanical index are sometimes match, sometimes they don't match. For example, here it's abnormal, and this case number 2, and the CBI is normal. And these make us get confused about whether it's telling you the truth, or is it something which we need to really go probing deeper. So to understand the real truth of understanding biomechanics, you have to come out of biomechanics machine-based parameters and start looking at outside the biomechanics machine parameters. And that's when we start understanding this better. And this is what I've been talking for the last year, is that your true picture comes only when you come out of the machine-based indices. Because machine just gives you, and you sometimes like this picture, everything is confusing, but it's not as confusing if you start looking at these 4 parameters. And that is what I want to explain. One is epithelium. Let's look at this patient here. He comes for a refractive surgery, -5 or refractive surgery. And look at this. There is an inferior steepening, nothing major on the posterior surface. Your 2 parameters are normal. The bad D is something on an abnormal way. But when you look at this area, you feel that you don't want to do it because there is definitely an inferior steepening out there. And when you do your epithelial mapping, the same area of inferior steepening has an epithelium which is thicker. It's a very interesting case because a localized epithelial thickness is something which can change your inferior parameters. So it is not an unhealthy stroma, it's an unhealthy epithelium, and that's why your biomechanics is normal, in spite of having an abnormal looking topography. So what we did for this case is we did the confocal just to see what was happening, and we have never seen such amount of Langerhans and dendritic cells. This is a huge amount. We don't really know what is happening. That's a different story at this point of time to go into this case, but this is something which epithelium has a huge role in masquerading the changes in your biomechanics. And without looking at the epithelium, reading your maps of biomechanics is definitely not the way to go. And this is a big take-home point because epithelium is not included in your biomechanical assessment. But if you don't, then we have definitely a challenge to understand it. So you have to take it up. That's a very important point. The second is when you look at any of these parameters, we always look at, is this collagen? Because the whole thing is about looking at viscoelasticity of the collagen. Is this collagen normal? So what we started looking at is the same set of images in a regular OPD, like your mix of it. Like sometimes your one parameter is normal, anything in green is normal. If the black band is towards the red, is abnormal. Your people using Pentacam know that the bad D being abnormal, the TBI, in this case, it's on the red side. The question is, what is the real truth? Are we, do we believe in a topography? Do we believe in this indices? So what we started doing is, we started looking at all these cases and started trying to prove what we are trying to see, because ultimately this question is asked by everybody. What do we believe in? So to believe in, or to make people believe in what you're seeing, you have to understand what you're studying. And what you're studying is the property of a collagen. And property of a collagen has to be imaged to understand what a property is. So what we started doing is we had our own system of evaluating it. And I've not shown this image in many meetings. Now we are able to give a topometric or topotype of imaging system. And you can see the darker the blue is healthier. And you can see that right and left eye. And this is exactly how an electron microscopy looks. And this is what we are giving results on our PSOCT. And you can now see these images are very, very good images, what we see. And you can see that the biomechanics is normal. So is your corneal collagen, and everything looks healthier. But now, when we look back at all the patients we have imaged so far, and now look at this. These are two biomechanically normal one, beautiful image of collagen, darker blues. When you have a slightly change in the biomechanics, especially the TBI, you still have a healthier biomechanics, but not totally bad. So that means in this case, the cornea is stronger. What you're seeing as a TBI may not be giving you, because this is heavily dependent on your topography. So when you have a indices which is dependent on a topography, you sometimes get it completely wrong. So that is sometimes we have to be very careful, because the TBI part of topography is heavy. TBI part of biomechanics is dependent on bad D and other parameters, and CBI is not. So that means it's matching very well with your collagen. As the CBI, as your corneal biomechanics changes, look at the collagen. The blue is becoming lighter. The lighter the blue, the worse it is. So lighter, when you see in keratoconus, you can see hardly the blues are there compared to the normal out here. And in a thick corneas here, again, the biomechanics is normal, but there is a loss. So what is happening here is now we are really seeing the change of why parameters differ. So what I want to say in this pattern is, when you have a topography being abnormal, your one parameters which is dependent on topography like TBI is showing always towards abnormality, even though the collagen is completely or near normal healthy. So for that, you have to probably look at the indices only looks at the image of the collagen, that is the CBI. So this is a very important finding. And this is the first time in this meeting I'm discussing this, which is just coming out with the data analysis. And this is, again, the parameters. And most important parameters is always look at corneal biomechanics with interest to the IOP. In this patient, you can see the IOP is lower. Your CBI shows abnormal, even though the collagen is normal. So that means if your IOP is falsely lower or artifactually lower, you will show a difference. So that means if the cornea is normal, just that IOP was lower compared to a higher IOP, and everything, even your CBI and the TBI parameters are healthy. So what is important here is that your measurements of IOP is also very important. Now coming to the last part of my talk, whatever I said, imaging matches a lot to your biomechanics. That's what the modern thing. This just to prove that sometimes when you have different parameters not matching, it's not that it's wrong. It's just that we have to go dig in a little deeper. So what we started looking at is, in the past, we've studied from the epithelium about different collagen. This is something which we have, I've worked with. This is what I'm driving now with the team of scientists and physicists, a lot of my young people. a more of personalized medicine using all the system. So what we did was we started looking at every time we do a surgery, we started looking at all the molecular factors and then comparing it with what the biomechanics and the Corvus was showing. So this is the only time you can combine three things. One, your imaging, two, your biomechanics, and three, what is the real thing happening in the eye? That's the real truth. The real truth happens when you send something for histopathology or microbiology or molecular biology. And the only time you can do it is when you do a smile or a PRK, because that's the only time you take in tissues. And we started taking in tissues and started seeing if this is matching. And what you can see is in this case, the bad D was on yellow. That it means that you consider this as an abnormal eye, but your biomechanics was normal. Now, the question asked is, who's telling truth? Should I go by the bad D on the pentagram or should I go by the biomechanics? So when we did this, I took a chance and I did the smile. I took the lenticule off and I studied the collagen and the lysyl oxidase, two most important component in your tissue, because I had the lenticule. And it showed that it was very healthy. There's absolutely no problem in that eye. That means the biomechanics was telling the truth. So, and the OCT, the PS OCT was giving me perfect values. So what did this case tell me? That a case where the bad D was abnormal and the biomechanics was normal, matched completely to the normal collagen and matched completely to the molecular format of collagen. That means virtually I banged this this diagnosis. And the second case had a biomechanics which was abnormal, borderline. This case I did the smile extra anyway because bad D was abnormal, and you can see that the collagen also was on a normal scale. So it means that it was matching exactly to the imaging and it was matching exactly to the biomechanics, even though it was having a permutation combination. If you just do a Corvus, you'll get confused. So now what I'm trying to do is make for people using biomechanics, trying to make an algorithm without using PSOCT, without using molecular, because this is not a standard of care and it's not going to be possible. So we're going to make it simpler, and that should probably happen this year. And even in keratoconus, you have different type of biomechanics. You can see that in different type of collagen. This is a progressive case, and you can see that there are new parameters like SSI index, which shows that as you progress, the eye is becoming softer, and this matches with the collagen imaging out here. What's the future? This is paper we published using AI and the prediction model. Now we have built a software which probably will be incorporated into a lot of into your own machines, where you can feed in data. This is an artificial intelligence-based software. We are collecting data. Shankar Netralaya is also part of this. Prema Padmanabhan is working closely with us. And this data will predict and tell us which procedure in this, if you plan one procedure on this eye using the biomechanics, which one would cause the least amount of corneal weakness. And this, based on that, you can do a personalized approach, or you can think about doing a cross-linking with it, or you can decide not to do it, or you can decide to do a smile or PRK based on all the stiffness parameters out here. You can tell you the pre-op, post-op, what happens to the stiffness. And this has been compared to thousands of eyes from our database. And this is a simple example which tells you about it. The future is using the Brilliant, and you can see the changes in each zone, but we have already showed with PSOCT that it does simpler than Brilliant and gives you much better results. In summary, it helps to evaluate the refractive surgery patient, but it cannot be used as a standalone one. You have to look at from epithelium and multiple other things. Keratoconus, fantastic tool to look at different types of keratoconus. Sometimes if you have a strong biomechanics, the keratoconus may not progress. So using this as a parameter when to operate is also important. And a stronger eye we don't need. And we use PSOCT just to prove what we're trying to say and how good the biomechanics is. And it also helps to look at cross-linking outcome and future I just mentioned about the software. Thank my entire team, and thank the society again for this opportunity and also giving me a few minutes extra time. Thank you.